So thank you very much for the opportunity to present our study about the correlation of homocysteine levels with lipid profile and coronary artery disease in patients with chronic kidney disease under hemodialysis. These are some preliminary findings. So there are non-conflicting interests in this speech. Homocysteine is an amino acid that contains a sulfhydryl group. It's important for the growth of cells and tissues. It is not provided by the diet, and it's normally formed through the methylation of an essential amino acid methionine. The normal range of homocysteine levels in the blood is 5 to 15 macromole per liter. And the classification of hyperhomocysteinemia is moderate, intermediate, and severe according to the homocysteine levels in the blood. So homocysteine has been implicated as an independent factor for atherosclerosis and consequently cardiovascular disease in patients with chronic kidney disease, and also appears to involve in the chronic inflammatory process. So in our study, 50 patients were included, 30 male and 20 female, with main underlying diseases, the hypertensive nephrosclerosis and diabetic nephropathy. They were all of end-stage chronic kidney disease for external dialysis over than 6 months, and all of them were over 18 years old. So our patients were divided into 2 groups based on the presence or absence of coronary artery disease, the use or not lipid-lowering treatment, and folic acid per dose. The biochemical assessment was at baseline at 6 and 12 months, and the examined parameters was homocysteine, triglycerides, total cholesterol, LDL, and HDL cholesterol. So in this diagram, we can see the change in homocysteine levels over the course of 1 year. At the first measurement, homocysteine levels were elevated in 21.89% of patients. In the second one, were elevated in the 26.62% of patients. And at the third measurement, they were elevated in 29.61% of the patients. Overall, during the year, there was an upward trend in the mean homocysteine levels compared to the normal values. So patients were divided in male and female, and there was no, in the first measurement, we can see that male have higher percentage of homocysteine levels than women, but the difference was not statistically significant, and as well as in the second 2 measurements. Now, patients were divided into 2 groups, receiving or not hypolipidemic treatment. Those who were receiving were 48%, and those who didn't were 52%. The use of hypolipidemic treatment did not significantly affect the change in homocysteine levels between the third and the third measurement, and not between the first and the third measurement, but overall, at the third measurement, patients who were receiving treatment had statistically significant higher homocysteine levels than those who didn't. From the division of patients in the study and those who received or not folic acid per dose, and the dosage was 5 milligrams per day, there was no statistically significant difference in homocysteine levels between the 2 groups. However, we should note that the number of the patients was not sufficiently large to draw conclusions for these specific questions, as only 7 of our 50 patients did not receive folic acid treatment. So homocysteine has been implicated as an independent risk factor for atherosclerosis and consequently cardiovascular disease. Contrary to the existing bibliography, this study observed that patients with CAD had statistically significant lower homocysteine levels compared to those without CAD. And in the correlation of homocysteine with a lipid profile, 64% has pathological levels of total cholesterol. The 72% had pathological levels of triglycerides, and 70% had pathological levels of LDL cholesterol. So in the first measurement, there was no correlation between homocysteine and HDL, and a borderline correlation with LDL. In the second measurement, there was a positive correlation between homocysteine and LDL, and as well as with total cholesterol. And in the third measurement, there was no correlation with homocysteine and with the studied parameters. So the objective of our study was to investigate the potential association between homocysteine levels, lipid profile, and coronary artery disease in patients with end-stage chronic kidney disease. Homocysteine levels were found to be elevated in the 78% of the patients, showing an upward trend compared to normal values over the course of 1 year. There was a higher prevalence of hyperhomocysteinemia in males, and they had 4% increased probability of a 1 logarithmic unit rise in homocysteine levels compared to females. There was no statistically significant difference in homocysteine levels between patients who received a node folic acid peros. Patients with CAD demonstrate significantly lower homocysteine levels compared to those without CAD. A statistically significant positive correlation was observed between homocysteine levels and low-density cholesterol levels. Also, LDL was found to be an independent and significant predictor of homocysteine levels, with 99% probability increase in homocysteine levels of 1 logarithmic unit per unit increase in LDL concentration. Patients receiving lipid-lowering treatment had significantly higher homocysteine levels. So in conclusion, homocysteine levels were found to be elevated in a high percentage of patients. However, there was no statistically significant association with coronary artery disease. In contrast, homocysteine levels were significantly associated with both cholesterol and LDL cholesterol levels in both patient groups. So this is our bibliography, and thank you for your attention. And